السلام عليكم. بسم الله الرحمن الرحيم. My name is Mohammed. I'm consultant cardiology in the King Fahd Military Medical Complex in Eastern Province. Today, I will take you in a journey to discuss the novel therapeutic options in the management of stable coronary artery disease. To start with, we have a big problem for ischemic heart disease. Why? Because ischemic heart disease is #1 killer worldwide. If you can see here, these are the common causes of death as reported by WHO in 2018, and ischemic heart disease comes as #1 killer, even before stroke, lung infections, and other causes of death. And the global burden of cardiovascular disease is affecting the whole universe. You can see here in this map, all the continents are affected with coronary artery disease. And if you focus more in our area in the Middle East, you can find in red, in dense red, our area is more affected with cardiovascular disease. When it comes to the Middle East perspectives as shown in this publication, you can compare our countries like Kuwait, Emirates, Saudi Arabia, and Egypt, and you can find the causes or the number of deaths or ischemic heart disease, strokes, and hypertension is more than double when we compare to UK, USA, and Germany. When we focus in Saudi Arabia, we have almost 37% of the premature deaths are related to cardiovascular disease, which is a big portion as well. It's not only about mortality, so let's talk about money as well. For the health economic burden of coronary artery disease is a big problem worldwide. In Europe, by 2016, Europeans spent almost 56 billion euros in relation to coronary artery disease. And in the States, almost 90 billion US dollar were spent by the government. And this cost is increasing for more and more cases of hypertension, more cases of heart failure, chronic artery disease, and strokes and atrial fibrillation. And this is why they are expecting in the USA by 2035, 15 years from now, that the coronary artery disease cost may reach 215 billion US dollar per year. And if you get for one patient, the 1 year cost for treatment of stable coronary artery disease, if the patient is only on medical treatment, it will reach more than 1,500 euros. And if the patient will go for PCI and stents, it may reach up to 6,000 euro. And if the patient will have CABG, this may be more and more euros. So to summarize, ischemic heart disease is a large heterogeneous group of patients. It may include stable coronary artery disease, which is the subject we are discussing today, and acute coronary syndrome. Acute coronary syndrome may include unstable angina, non-STEMI, and STEMI. So let's focus more about the stable coronary artery disease. Sometimes we call it stable angina. So do we think that stable angina is that much stable? Actually, the prognosis of stable angina or chronic angina is not that much good, because annual mortality may reach 2% per year, and the rate of cardiac death is almost 1.4% per year. And if you can see here, this is the normal life spectrum for a patient without angina or ischemia. And once the patient has ischemia or angina, even without proven ischemia, there is reduction in the life years that patient expected to live. So angina and ischemia are associated with less longevity. This is why the European Society of Cardiology Guidelines 2019, less than 1 year, they replaced the terminology of stable coronary artery disease because it's not that stable. It's giving false reassurance about a serious disease. And now it's named as chronic coronary syndrome. We should not label chronic coronary syndrome as stable angina anymore since the last August 2019. So what is the epidemiology of chronic coronary syndrome? Internationally, in the middle age, it's ranging from 4 to 7%, while in older population, it may reach up to 14%. So this is a quite common. So internationally, we expect that more than 100 million of patients is affected globally with angina. What about chronic coronary syndrome in the kingdom here? Actually, the prevalence in the kingdoms for chronic coronary syndrome is 5.5% in the middle age. It's affecting urban areas more with a famous comorbidities we are meeting every day, like hypertension, diabetes, obesity, and metabolic syndrome. And chest pain as a symptom is one of the most common symptoms that people are having here. It affects 1 in each 4 adults, and almost 20% of this will have associated coronary artery disease. And some patients have duration of chest pain up to 5 years. So chest pain is one of the commonest presentations in the OPD and hospital generally. What are the mechanisms of myocardial ischemia? Is it the same? The answer is no. Myocardial ischemia is very complex disease. First of all, you can find the patient have focal epicardial coronary artery disease, and this is common actually to find the lesion, discrete lesion in one of the coronaries. But this is not the whole story. Sometimes patients may have epicardial vasospasm, and vasospasm can be related to drugs or can be related to individual variability. And some patients may have myocardial bridging. Myocardial bridging means that part of the coronary vessel is taking a dive in the myocardium, so it will have some squeeze during systole. Another form of myocardial ischemia can be related to diffuse coronary artery disease. Sometimes you cannot find a discrete lesion, especially in diabetes. You will find whole vessel is attenuated and diffuse disease. Other common reason for myocardial ischemia can be endothelial dysfunction, especially in smokers. And of course, microvascular dysfunction is very important reason to have ischemic heart disease, especially in diabetics. And as you know, we have large percentage of our patients are diabetics. In coronary atherosclerosis, it's like a tip of iceberg. What we see in the coronary anatomy is only little because we see the large epicardial vessel, while the microcirculation is large, and most of this we cannot see and may be affected in some diseases, especially in diabetes. So after talking about the mechanisms of chronic coronary syndromes or mechanisms of myocardial ischemia, how can we manage chronic coronary syndromes? Like everything in medicine in 2020, we have options. We can treat anything medically, interventionally, or surgically. So let's first focus on consideration of medical therapy. As we just discussed, these chronic coronary syndrome patients are large heterogeneous group. Patients are not the same. So some patient-related factors should be considered, like what is the possible mechanism of ischemia? Is this can be related to focal lesion? This is microvascular dysfunction, may be related to smoking, so this patient may have a spasm of endothelial dysfunction. What is the patient age? I'm treating the patient in 30s in a different way if the patient is 90 years old. What is the comorbidities and what is the tolerability of the patient? How much the patient will tolerate my option of treatment? Then the drugs. Each drug has its own mechanism of action and it should match the mechanism of ischemia the patient has. What is the evidence of the efficacy for such a drug? What is the safety of the drug, which is very important, and possible drug interactions? And what is the cost effectiveness? So comorbidities play important role in the decision which drug should I give. So for example, if the patient has myocardial ischemia and atrial fibrillation or heart failure or hypertension, what if the patient is bradycardic? For each clinical scenario, we should tailor our medical treatment as at the best to fit the patient. So the $1 million question, drugs only versus revascularization. In other terms, should all patients be referred to cath lab? Should we stent or the patient or to do CABG, coronary bypass for all the patients, or just give medical treatment? This is a very hot topic. And one of the most important trials discussed this before was the COURAGE trial. COURAGE discussed whether PCI versus medical treatment for stable angina, and it did not find any difference between them. And many publications came later, and all these publications, you can see here the conclusion, there is no statistically significant difference between PCI and medical treatment. We did not detect difference between PCI versus medical treatment, and another publication, PCI versus optimal medical treatment did not reduce the risk of mortality, and there is no benefit. So we have a plethora of data that's showing that medical therapy is a standard, and there is no advantage if you go directly to PCI such patients. More recently, in The Lancet, there's a famous publication for the Ortica trial that gives almost the same conclusion. And most recently, the very famous ischemia trial, and it was published in New England Journal of Medicine, and it gave almost the same conclusion. So let's explore this inclusion because this is very important trial. Among patients with a stable coronary disease and moderate or severe ischemia, we did not find evidence that initial invasive strategy as compared to initial conservative strategy could reduce the risk of events or death. So medical treatment did well or did the same like PCI, even if in patients with moderate or severe ischemia. So when today we are telling that optimal medical treatment is the cornerstone in the patient with chronic coronary syndrome, this is not opinion, this is a fact, and this is a guideline recommendation. So this means that there is no indication for revascularization chronic coronary syndrome. The answer is no. We still have indication of revascularization, like for prognostic reasons. If the patient has left main disease, or the patient has proximal LAD or diffuse multivessel disease with LV dysfunction, this revascularization will be prognostic. And on the other hand, if the patient still has symptoms on the medical treatment, then we have very good indication to go for percutaneous intervention. Please do not get confused when we are promoting optimal medical treatment for chronic stable angina. Why? Because there is acute coronary syndrome like non-STEMI or STEMI where revascularization proved to save life and time is muscle, as we always say. On the other hand, in the other population, which is chronic coronary syndrome, then the optimal medical treatment should be the initial strategy. So it's not the same. Acute coronary syndrome, go invasively and revascularize. If the patient has chronic coronary syndrome, the opinion is different, and then optimal medical treatment is the initial strategy. But did you notice that it's not only medical treatment when we are discussing the optimal treatment? We need to have optimal medical treatment when we go for treatment of chronic coronary syndrome. So the question is, what is the optimal medical treatment we should offer to our patients? According to most of the recent guidelines to treat chronic coronary syndrome, we have two targets when we are treating patients with stable angina. We have to make angina relief or symptomatic treatment, and we have to give event prevention, which is the prognosis of the patient. The most important is event prevention. It can be with lifestyle modifications. The patient should exercise, should lose weight, stop smoking, and we should control the risk factors, control diabetes, and of course, the basic treatment for event prevention in such patients, including aspirin, statin, and ACE or ARBs. So what about angina relief? On the other hand, on the other way, angina relief, usually we are giving the patient short-acting nitrates, sublingual nitrate, for example, and we should give the patient first-line treatment, which is beta blocker and or calcium channel blocker. These are the first line to treat patients to relieve angina. So what if the patient still symptomatic, still having angina? Then we have to consider a second line anti-angina, which are including ivabradine, nitrates, nicorandil, ranolazine, and trimetazidine. If we used already the second line and still the patient is symptomatic, then we should consider to go for cath lab, PCI, stent, or cabbage. So this is the scheme. How should we think of treatment in a patient with chronic coronary syndrome? This is in agreement with the NICE guidelines as well, that put the second line anti-anginal drugs after calcium channel blockers and beta blockers, then go for nitrates, ivabradine, nicorandil, or ranolazine, and we will discuss that. In the most recent 2019 European Society of Cardiology guideline for the diagnosis and management of chronic coronary syndrome, it stated that nicorandil, ranolazine, ivabradine, or trimetazidine should be considered as a second line for treatment to control angina when the patient still is having symptoms not controlled by beta blocker, calcium channel blockers, and long-acting nitrates. So let's focus on the new medication or the second line anti-anginal drugs. What we have in this year? Actually, we have trimetazidine, which is a good drug. It acts through metabolic modulation of the energy production inside the myocyte, and ivabradine, which is helping to control the heart rate of the patient by sinus node inhibition, and ranolazine, which is late sodium current inhibitor, and the drug we will discuss today, Nicorandil, which is acting on preconditioning. These are the four second-line anti-anginal drugs we may have in 2020. But honestly, ivabradine is no more available in my center and most of the centers, and now it has clear Saudi FDA approval for treatment of heart failure. So it's not that much viable option today. And ranolazine still not available in the Saudi market. So of these drugs, we have trimetazidine or Vasterel, and we have Nicorandil. And Nicorandil is acting through the preconditioning. So let's give short slides about ischemic preconditioning, or as I like to term it, it's art of surviving. So, for example, this is a tulip farm from near Amsterdam in the Netherlands. And this is another flower that I found on my way in the street. It gives its way between the stones, as you can see. So let's imagine both flowers, the tulip and our flower here. are exposed to temperature of 45 degrees with direct sun exposure like we have nowadays, with no water for 1 week and dusty day. So, which flower would survive longer? I think we will all agree that this one can survive longer because it's trained to have direct sun exposure, trained to have a difficult time with no water. And this is actually what we learn from the nature. And this is what we call ischemic preconditioning. So the when we go back to the heart, in this publication, they divided the control group and the preconditioning group. In the preconditioning group, they induced a brief ischemia. So in a myocytes, they will stop the blood flow of the coronaries for a brief time and then allow. Then another brief ischemia, then allow the flow once more and then another ischemia. And the control group did not have any brief ischemia. Then both will have the same prolonged occlusion of the coronary vessel. And then they allow the reperfusion together. So what will happen? In the preconditioned muscle that had experienced ischemia before, the infarct size will be small. If you compare that with the control group that never had the stress of ischemia before, for the first time of ischemia, it will have a large infarction. And this is the idea of training. The preconditioning is a training of the subject. Here is training for the myocardium. Once it has these difficult scenarios in training, then once it has the occlusion, it can tolerate the occlusion in a better way than the control group that never had stress before. And this has been proven that previous angina, when the patient has previous angina before his myocardial infarction, the size of myocardial infarction usually is smaller than the first timer. He just has this myocardial infarction without any preconditioning, then it will be large infarction. And this is why we have patients, sometimes we have patients 30 years old, he had first time chest pain with anterior STEMI, and then the patient had drop of ejection fraction even after revascularization and even after stenting, the patient will have ejection fraction down to 25%, while other patients who had previous events may have MI without this large drop in the ejection fraction. So this is the ischemic preconditioning or the idea of preconditioning. So let's focus on the drug that we are discussing because it will have the effect on the preconditioning. This drug is Nicorandil. And Nicorandil, as we just discussed, is a second-line anti-anginal agent. It's available in 10 and 20 milligram doses. And it is indicated for long-term treatment of chronic angina. It has 10 milligram as a starting dose and 20 milligram as maintenance dose. It's usually taken BID. It's mainly hepatic elimination. It has no drug dose adjustment requirement for mild to moderate hepatic or renal impairment, and this is good. And it has a steady state plasma concentration after 4 to 5 days. It has anti-anginal effects for 12 hours. So what is the mechanism? What is the mechanism of action of this Nicorandil? Actually, Nicorandil is a potassium channel opener in the vascular smooth muscle cells. So what is the benefit? So how it will work and how it will affect the preconditioning? So Nicorandil has a hemodynamic mechanism. How? It has a dual action. Part of its action is nitrate-like action. It behaves as if it's nitrate. So it will dilate epicardial coronary arteries. Once you dilate the epicardial coronary arteries, you have better coronary blood flow. And it will induce some venodilatation. And this venodilatation will decrease the preload. So this will relieve the heart. This is one action. The other action through its potassium ATP channel opener. So what happens when we have this potassium channel opener? We will have dilatation of the peripheral arteries. This will decrease the afterload, and this again will decrease the oxygen demand for the patient. On the other hand, it will have dilatation of the coronary microvessels, and this is advantage over nitrates. It will affect not only the epicardial vessel, it dilates the microvasculature. So it will be associated with increase in the coronary blood flow as well. So these are the hemodynamic. What about the cardioprotective mechanism? The cardioprotective mechanism of Nicorandil is mainly related to mimic the ischemic preconditioning we just give idea about. Why? Because it's opening again the potassium channels. So as we know, the preconditioning or the training of myocardium is mainly by ischemia. Once you have ischemia, you will have the training program of the myocytes to have to face the next stress in a better way. It will have some adaptation of the myocardium to the ischemic stress. But this ischemic precondition can be pharmacological as well. How? By potassium channel opening. By sarcolemmal potassium channel opening, it will have more potassium efflux during repolarization. It will prolong the myocardium resting state by having hyperpolarization of the cardiac cell membrane. This is one way. Another way, by mitochondrial potassium channel opening, it will decrease the calcium toxicity inside the cells, and it will increase the cellular tolerance to stress. So, ischemic preconditioning we are facing clinically, we can mimic it pharmacologically by Nicorandil plus its hemodynamic value. So this is theoretical. Let's go for the evidence. Do we have evidence for Nicorandil in the clinical practice? The answer is yes. But is this evidence related to prognosis or the symptoms relief? Actually, we have both. So let's go first for the prognosis. The Nicorandil reduced cardiovascular events in patients with coronary artery disease in many trials. Here you can notice 17 randomized controlled trials, including more than 7,000 patients. And in these trials, or most of these trials, as you can see here, the intervention with Nicorandil improved the outcome or reduced the cardiovascular events. One of the most important evidence we have for Nicorandil is this trial, IONA trial. IONA is British trial. It is impact I of Nicorandil in angina. So this is IONA trial. IONA trial included more than 5,000 patients, and they are randomized to 20 milligram Nicorandil twice daily or placebo. And average follow-up was 1.6 years. The primary endpoint was coronary artery death, non-fatal myocardial infarction, and unplanned hospitalization for chest pain. Secondary endpoint was coronary artery disease, death, plus non-fatal myocardial infarction. So in short, IONA trial included 5,000 patients randomized to Nicorandil versus placebo. It was double-blind randomized controlled trial, and the patient started by 10 milligram as the starting dose of Nicorandil and increased to 20 milligram BID after 2 weeks. What about the demographics, the patient population? Most of these patients were male, and about 2/3 of these patients had previous myocardial infarction, and only 8% of these patients are diabetics. If we have this trial in our population, definitely we'll have a larger number of diabetics rather than 8%. Concomitant medication, the patient had beta blockers, ACE, diuretic, nitrates, aspirin. All the medications were taken in this study group. And what about the results? The results, the primary composite endpoint of cardiovascular death, non-fatal myocardial infarction, or hospitalization was dropped by 17% with patients receiving Nicorandil. And secondary endpoint, composite endpoint of cardiovascular death and non-fatal myocardial infarction was decreased by 21%. As you can see here, this is the graph of the primary endpoint, which is a composite cardiovascular death, non-fatal myocardial infarction, or hospitalization. It showed 17% relative risk reduction, and this benefit was noted early since the start of the early days of start of the medication. And this data was consistent in all endpoints detected for the trial. So what about the safety? Safety of this Nicorandil in our population. Actually, overall rates of serious adverse events were similar in both groups. There is no much difference between the placebo and Nicorandil. And what about the hypotension? This is a vasodilator. Did we have hypotension? Actually, the mean changes in the blood pressure was about 4 millimeter mercury decrease in the Nicorandil arm. So this is not much as a side effect as you can expect for a vasodilator. This is one trial. We have another trial, which is Japanese trial. This is the Coronary Artery Disease Study, or Japanese Coronary Artery Disease Registry. This registry in Japan included more than 13,000 of patients with stable coronary artery disease. More than 2,500 patients were treated with Nicorandil and follow-up for 2.7 years. And as you can see, at the results of this registry, there is 35% reduction in all-cause mortality in the Nicorandil arm. Not only that, there is a significant reduction in the fatal myocardial infarction in the Nicorandil arm compared to control arm. So as a conclusion of this JCAD, or Japanese Coronary Artery Disease Observational Study, there is 35% all-cause mortality reduction, and the secondary endpoint of cardiac death and myocardial infarction was reduced by 56%. So we have good evidence for Nicorandil for the prognosis or event reduction. What about the symptoms relief? This is a mainly symptomatic treatment. So symptom relief, is it effective? The answer came in this paper. This is a Chinese paper, which is double-blind, multi-center, active control randomized clinical trial to assess safety and efficacy of Nicorandil in a stable angina in China. And this trial randomized patients to Nicorandil versus the old friend, which is nitrate, isosulfide mononitrate. And in conclusion, the results came that Nicorandil significantly decreased the number of anginal attacks and the nitroglycerin consumption of this patient. And this reduction came to almost 50% less anginal attacks when the patients are taking Nicorandil compared to nitrates. And this is the graph. It showed that Nicorandil in green has more than 50% reduction in anginal attacks compared by nitrates in blue, and more reduction in nitroglycerin consumption in comparison to nitrates. So now mission accomplished. We have good evidence for prognosis, we have good evidence for symptoms relief, and there is again more evidence post-primary PCI. In this paper published in Journal of Cardiology 2012, They used oral treatment of Nicorandil at discharge after myocardial infarction treated with primary PCI, and they found in such population there is 43% reduction in all-cause mortality. So this paper was named OASIS, the Osaka Acute Coronary Insufficiency Study, it's Japanese trial. And as we just discussed, it's 43% reduction in all-cause mortality. So the evidence is very clear, but the question is still there. Nicorandil is acting somehow like nitrates. So which is better? Or is there any competitor between Nicorandil and nitrates? Actually, nitrates has been there since very long time, and it's used by Alfred Nobel to invent the dynamite. And the anti-anginal effect of nitroglycerin has been reported in the Lancet in 1879, more than 125 years. And for more than 100 years, it stayed as first line of treatment of coronary artery disease generally. But what is the mechanism of action of nitrate? Actually, nitrate is a nitric oxide donor. It's a vasodilator. It's mainly venodilator to decrease the preload, and it has some effect on the epicardial coronary vessel. So what nitrate preparations we have? We have the short-acting nitrates, we have the sublingual nitrates, and we have the long-acting nitrates, either isosulfide, dinitrate, or mononitrate with longer action, and the nitrate. So do we have really evidence for nitrates for coronary artery disease? Do we have to have evidence for a drug that has been used for more than 100 years? We have examples like digitalis. Digitalis has been used in treatment of heart failure for long years and was labeled as the treatment of heart failure. And nowadays, what happened? We found that digitalis is not that much effective, and now it's not used in most of the patients with heart failure. Is it the same for nitrates or nitroglycerin? Actually, the evidence we have for nitrates is not much strong. We do not have much data about that. We know since long time it's a drug of the heart, a drug for heart attacks, and there is no evidence of safety or efficacy when it's added to beta blockers or calcium channel blockers. On the other hand, there are concerns about the use or safety of long-acting nitrates. We have a phenomena which is time zero effect. Time zero effect means that the exercise tolerance just prior to the morning dose of nitrates usually is decreased. This is what we call time zero effect. There is rebound angina. If the patient is chronic treatment on nitrates and then stop, they may have rebound angina. We have tolerance of nitrate. This is why we have to give our patients nitrate-free interval. And recently, we discovered that long-term or long-acting nitrates can be associated with endothelial dysfunction. And this is one of the papers that international observational registries together included more than 2,000 patients, and they found that there is increased risk of death associated with long-acting nitrates in ACS survivors. Could this be related to endothelial dysfunction? This paper was published in European Heart Journal 2013 and isosulfide 5-mononitrate and endothelial dysfunction. In another term, a wolf in sheep's clothing. So is it really beneficial drug, or because of this endothelial dysfunction, this might be injurious to our patients? And the opinion from the European Society of Cardiology 2013 guidelines for management of stable coronary artery disease, they labeled that long-acting nitrates may worsen the endothelial dysfunction which is a potential complication of long-acting nitrates. On the other hand, we have evidence that Nicorandil improves the endothelial function. So, in general, what is the main differences between the Nicorandil and nitrates? First, Nicorandil show better anginal relief when compared head-to-head with nitrates. Second, Nicorandil is able to reduce both the preload and afterload, and remember that nitrates mainly affecting the preload. Nicorandil is able to dilate diseased vessel and healthy vessel as well. So there is no cardiac steal phenomena that may have been there with nitrates. And patients do not develop tolerance to Nicorandil, so that we do not need nitrates-free interval or Nicorandil-free period like we need for nitrates. So in comparison, this is my opinion, Nicorandil is the winner when compared to nitrates because of it's more effective, there is no tolerance, and we have evidence that it is associated with more prognostic effect with less cardiovascular events in the Nicorandil arm. But nothing without cause. Every drug on earth has its side effects. What about the Nicorandil? Nicorandil has some side effects like headache, but this headache is much less if compared to the headache of nitrates. It may have some flushing because it's vasodilator. Hypotension is not that much. It's in average 4 millimeter mercury systolic change in the blood pressure and has some GI ulceration effect. But the very important notice is the drug interaction with phosphodiesterase inhibitors, the drugs used for erectile dysfunction. It is contraindicated to be taken while the patient is actively on Nicorandil. The trimetazidine is a good drug as well, but remember, this drug is should be avoided in moderate renal impairment and in elderly as well. I'll not go through ranolazine, we do not have still till now in the Saudi market. When should we avoid Nicorandil? In severe heart failure, in shock, in hypovolemia, or RV infarct. So let's have a practical case presentation. This is a 55 years old male. He's a hypertensive, diabetic, and dyslipidemic smoker. He has been known that he has coronary artery disease, and he had this coronary angiogram. The patient is having, this is the right coronary artery, it's diffusely disease from its ostium, and it is totally occluded in the proximal segment. The left angio is showing diffuse disease of the LAD and endothelium. So this patient can be labeled as diffuse coronary artery disease. And the appropriate treatment for this patient, whether CABG, PCI, or optimal guideline-directed medical treatment, we put this patient on medical treatment. So in follow-up, what happened? The patient in optimal medical treatment, which is aspirin, the baseline for treatment, Concord 10 milligram, Prendoprel 10 milligram, the patient on dyslipidemia management, which is aggressive, like atorvastatin 40 plus ezetimibe plus evolocumab, which is Repatha, the new drug to treat dyslipidemia. The patient on calcium channel blocker Amlor, and the patient is receiving sublingual nitrate 5 milligram ARA. And the patient experienced severe headache when he had isosulfide mononitrate, that he could not tolerate the nitrate. So when he came, the heart rate was 55 beats per minute in a normal sinus rhythm. The blood pressure is well and good. It's 115/78 millimeter mercury. And LDL is within target. It's 42 milligram per deciliter thanks to atorvastatin, ezetimibe, and Repatha. But the patient is still symptomatic with class 2 angina. What are the therapeutic options? We have to go for the second-line anti-anginal treatment. So can we give Nicorandil, azosulfide mononitrate, trimetazidine, ivabradine or ranolazine. Actually, we just discussed this patient experienced severe headache with nitrates. So nitrate is not an option for such patient. Second, as we just mentioned, the heart rate was 55 beats per minute. So actually, no need for ivabradine for this patient. His heart is within target. And as we just mentioned, ranolazine, we do not have ranolazine in our market. So the second line anti-angina that can fit this patient is Nicorandil, 10 milligram as a starting dose to be upgraded to 20 after 2 weeks, or trimethazidine, or both together. In this case, we went with Nicorandil 10 milligram. So, in summary, ischemic heart disease is #1 cause of death worldwide, and chronic coronary syndrome represents social and financial burden. Medical treatment is a cornerstone for management of chronic coronary syndrome, and all guidelines recommend the use of second-line anti-anginal treatment for symptom relief and event reduction, if we have proven that. Nicorandil is a safe and effective option thanks for its dual mechanism action and with superior angina relief compared with nitrates, with no tolerance for rebound angina. So this is my conclusion for today, and thank you for your attendance and attention. And now I received some questions we can go through. First question, and now it's the trend nowadays to receive such question. Whatever presentation I'm giving nowadays, I'm receiving question about the COVID-19, even if it is not related to my presentation, and I understand this because this is the main topic and the hot topic we have nowadays. So I have a question. Is acute coronary syndrome a complication of COVID-19? And if so, what is the mechanism and what is the incidence? Actually, we are having patients with COVID-19 with picture mimicking acute coronary syndrome. The heart is part of the body, and if the patient has generalized inflammation or the hyperimmune response that the patient is having in the third phase of COVID-19 infection, the heart can be affected, and myocarditis is a quite common, and this myocarditis can induce some troponin leak. Usually, any acute illness can be associated with a secondary involvement of the heart or troponin leak, and this is part of the myocarditis, part of the generalized inflammation the patient has. So yes, the patient may have picture of acute coronary syndrome. Most of these cases, this is secondary to the hyperimmune response or the inflammation the patient has. And we are encouraging to treat this patient conservatively unless it's a very clear picture of thin or diffuse ECG changes or very clear picture of acute coronary syndrome. So we have to differentiate between acute coronary syndrome in a patient suspected COVID or a COVID with acute illness, and most of these patients have a myocarditis. And we had experience, or we shared the experience with our colleagues from Italy, from Spain, and from New York. And most of this experience is don't push these patients directly to the cath lab, give them time to conservative treatment. And most of these patients are having diffuse inflammation rather than classic type of myocardial infarction. So this was the first question. So second question, again related to COVID-19. Do patients on Nicorandil have any protection in COVID-19 patients? The answer is we don't know. So if their protection COVID-19 was still, we have lots of unknown. So whether this drug can help or cannot help, till now we have no treatment. Dexamethasone now is the trendy medication. It may help. Maybe we'll discover that after a few days it's not helping. So for treatment, Nicorandil is a treatment for chronic coronary syndrome. Has nothing to do. We have no evidence it will have any effect in COVID-19. How does Nicorandil compare with the other second-line anti-anginal medications? The head-to-head comparison we have is between Nicorandil and nitrates, and definitely Nicorandil is more effective at angina relief and more than 50% reduction in anginal attacks when compared to nitrates. But we do not have head-to-head comparison with ranolazine. But the simple answer is we don't have ranolazine in the market. What about the ivabradine? Ivabradine has another mechanism of action. So, although it's not Saudi FDA approved the ivabradine for treatment of chronic stable angina nowadays, it's only approved for treatment of heart failure, but there is evidence that it helps in such patients. So, if the patient has maximum tolerated dose of beta blocker and calcium channel blocker and still his heart rate is high, so I would think of ivabradine to control the heart rate. But if that, like our patient, now he's on Concord, 10 milligram, heart rate is 55, resting heart rate 55 milligram. So what is the value of ivabradine in this patient? So definitely I would go for Nicorandil. Can we give an old patient with coronary artery disease dual antiplatelet to decrease the incidence of myocardial infarction? The answer is yes. In selected patients, especially high-risk patients, and especially patients with polyvascular atherosclerosis. So if the patient has combined coronary artery disease, cerebrovascular disease, peripheral arterial disease, when the patient is diabetic, if the patient has coronary ectasia, these patients, if the patient has two of what I just listed, these are very good indication to add a second antithrombotic agent for the patient. So aspirin plus. The plus can be clopidogrel, 75 milligram. It can be a very good option. Recently available in the market, the vascular dose of rivaroxaban, which is 2.5 milligram BID, which again is very, very good and proved to save life in such patients. One of the options can be ticagrelor, but in the smaller dose, 60 milligram, it will be very soon in the market. So the simple answer is yes. Dual antithrombotic can be used in a selected patient with chronic coronary syndrome, and the more the risk, the more the benefit, but be safe and consider the bleeding risk as well. So if the patient, yes, is 70 years old, but he has no renal issues, he has no high risk of bleeding, then I would go for either dual antiplatelet or what we call dual pathway inhibition, which is aspirin plus rivaroxaban vascular dose. Rivaroxaban vascular dose, 2.5 milligram, not the full dose. So, do we have to avoid nitrates in acute coronary syndrome? The answer is no. Nitrates still are used in the setting of acute coronary syndrome, especially if you are working in a non-cath lab facility. So if you have patients, we have ICU, and you are dealing with patients with acute coronary syndrome and patient has ongoing pain, no nitrates is good, especially when you are giving IV nitrates for acute coronary syndrome. The claims that the risk is there is related to the long-acting nitrates or the chronic use of nitrates. Nitrates still there. Nitrates is old friend. We have some concern about nitrates, but this does not mean that we should stop nitrates. Nitrates in acute coronary syndrome, either sublingual or IV, is still beneficial and can be used. But when you are treating the patient for long-term or chronic coronary syndrome, then you may have better options than nitrates. Nitrates is available, is cheap, is when it is well tolerated by the patient, it's good, but it's sometimes not very well tolerated, and the headache of nitrates for anyone did not try nitrates, a headache is miserable. And I remember some of my patients, even during intervention, when you are giving nitrates in the coronary, inside the coronary, very small in mics, 100 mics, 200 mics inside the coronaries, some patients are experiencing headache that after 2-3 months from the procedure, they tell me, I did not feel any pain during the procedure, during the stent, during everything, except I had headache at a time. So nitrate may induce headache, and this can be very bad for the patient. We can combine nitrate and Nicorandil together. The answer is yes, we can combine together, and Nicorandil can be added to trimetazidine as we just discussed. We can add to ivabradine. You can use them together. And according to the European Society of Cardiology, the latest guideline 2019, we will choose between Nicorandil, trimetazidine, ranolazine, on top of calcium channel blocker, beta blocker, and long-term nitrate. Difference between acute coronary syndrome. I think what is the difference, if I understand well, what is the difference between acute coronary syndrome and chronic coronary syndrome? Generally, coronary is the main blood supply of the myocardium. So when there is insufficiency of the blood flow in the myocardium, there is ischemia, myocardial ischemia. This myocardial ischemia can be of two forms. It can be acute occlusion. This acute thrombotic occlusion is what we call acute coronary syndrome. How to know about that? This patient will have acute onset, severe, prolonged chest pain. This patient may have accelerating angina over the last 1 week, 2 weeks. He will have frequent attacks of angina, or he will have all of a sudden prolonged chest pain from rest. The difference is chronic coronary syndrome, there is no thrombotic occlusion. The patient is having some narrowing in the coronaries. So when this patient will have some exercise, he will develop chest pain. If this patient relaxes, then the pain disappears. So this is another category. So acute coronary syndrome means patient in acute pain. The patient should be in the hospital. The patient should be in the CCU and should be treated invasively. The chronic coronary syndrome means that the patient is well. This patient may be in the street, maybe your colleague at work, maybe in the cinema. So this patient is a chronic patient. He will have pain only when he has exertion, when he has stress in work, when he has to fight with his wife, then he will have chest pain. But after this, or after he's taking sublingual nitrate, this pain disappears and he is normal person. So this is another patient, and this patient should be treated medically. So this is the main difference between the two categories. That question, this is a very practical and nice question. Nicorandil is once or twice per day. It's BID, should be taken twice. Starting dose is 10 milligram BID, and after 2 weeks, if the patient is well tolerating, blood pressure is well, then give the 20 milligram BID. So it's twice daily. Can Nicorandil be used for peripheral vascular disease? No data. Role of aspirin as prophylactic against the stroke and angina as adjuvant with nitrates. Actually, aspirin, the role of aspirin is very basic, and aspirin for secondary prevention, it's universal acceptance that for secondary prevention or for treatment of patients with stable angina or chronic coronary syndrome, the rule is there, it's +1 indication, no doubt to have aspirin. And then the question, should we add something with aspirin, another antithrombotic or no? If you have read any doubts about aspirin use, it's mainly for the primary prevention and for healthy individuals. In old days, we are advising that once you are 40, just take aspirin for your prevention, but then it's not that much beneficial and the bleeding risk is there. So the debate is for primary prevention, so we are saving aspirin mainly for the higher risk patients. You can calculate the patient risk or event rate, and once you have moderate or high risk patient, definitely we should give aspirin. But for secondary prevention or patient with proved atherosclerosis, the role of aspirin is there. It's sure and there, and no doubt about that. Is trimetazidine has less side effect than Nicorandil? There is no head-to-head comparison between these drugs. Trimetazidine is present in the Saudi market since longer time. It's very well tolerated drug. It has no problem to be added on the other medication or to be combined with nitrates or Nicorandil. It's not a competitor, but when you feel this patient, you exhausted the vasodilator pathways for the patient, or you need no hemodynamic effects, especially if the kidney function is okay, go for Pastorel or trimetazidine. If you still feel this patient may benefit from the improvement of endothelial function, vasodilatation, or you want to combine both together, because believe me, with the diabetes and character of patients we are facing, especially with metabolic syndrome and obesity and diffuse atherosclerosis, we need to give all our weapons for the patient to give them better quality of life, because chest pain and limiting chest pain is intended affecting very bad the quality of life of the patient. How can we deal or avoid side effects for GIT ulcers for Nicorandil? Actually, most of our patients are receiving gastric protection, especially if they are on aspirin or dual antiplatelet or polypharmacy like the patient we have. We have to follow up the patient like we are doing. Once the patient has symptoms or has any problem, then we can refer the patient to gastroenterologist, and this is not that much common. And remember, in the IONA trial, the serious side effects was almost the same between placebo and Nicorandil. There is no statistical significant difference. Yes, some patients may develop side effects, but with follow-up, and you will ask the patient if he's doing fine, if any symptoms or recent problems, then you will discover if the patient has side effects, and then you can change the drug or give him more protection or any other intervention. So these are all the questions I received, and I think it's time to conclude. So thank you all. I hope that our meeting today was fruitful for you and was fruitful for me as well. And enjoy a safe and nice night. Thank you very much.